This is a presentation on the renin-angiotensin-aldosterone system. There's two pressures that I want to talk about first before we talk about activation of the renin-angiotensin-aldosterone system. And the first one has to do with your mean arterial pressure. Your mean arterial pressure normally is between 70 and 110 millimeters of mercury. And your kidneys work very well when your mean arterial pressure sits between 70 and 110. So you don't want it too low, but you also don't want it too high. Because if your mean arterial pressure is too high, then those vessels in your kidneys are too vasoconstricted and you're not getting enough pressure within your kidneys. Okay? So you don't want it too low, you don't want it too high, but you want it just right. Patients who have undiagnosed hypertension, who have been with undiagnosed hypertension for several years, sometimes will get blood work done finally, and the physician notices that the patient has compromised liver or kidney function, and it has to do with the fact that their mean arterial pressure has been too high for too long. The other set of pressures I want you to keep in mind is 60 to 90 millimeters mercury worth of pressure. So in a normal capillary bed in your body, your normal capillary pressures sit around 35 millimeters of mercury. So when your blood comes out of your aorta at 120/80 and it goes all the way down through the arterial system and it goes down to the capillary system, those normal capillary membranes sit normally around 35 millimeters of mercury. Then the blood goes back up to the heart, and when it finally gets back to the heart, normal right atrial pressures are about 2 to 6 millimeters of mercury, according to your book. Your kidneys, though, like 60 to 90 millimeters of mercury within its glomeruli in order to work appropriately. So even though your normal capillary bed pressures are at 35, unless those pressures are high enough in your kidneys, then they don't work well. So your kidneys, like I always like to say, your kidneys love a lot of pressure in order to work, between 60 and 90 millimeters, or again, a systemic mean arterial pressure between 70 and 110. But if they're not getting enough pressure, what's going to happen is they get a little cranky, and renin is going to be secreted. And when renin is secreted, it converts angiotensin 1 to angiotensin 2 by an enzyme called angiotensin converting enzyme, or better known as ACE, A-C-E. Okay, angiotensin converting enzyme. And when angiotensin 2 is formed, there's a couple things that happens. Number one, you have vasoconstriction, systemic vasoconstriction. So if you have systemic vasoconstriction, your blood pressure is going to go up, and hopefully that means that those pressures then are going to increase within the kidney. It also means when you have vasoconstriction that you have vasoconstriction within the glomeruli in your kidneys. And with that, then you're also going to increase that pressure within your glomeruli, and your kidneys should work a little bit better. The other thing that happens is you have aldosterone release from the adrenal glands. And when you have aldosterone release, it basically causes sodium to be retained. And when you retain sodium, you also retain water. So if you retain sodium and water, you increase intravascular volume, which hopefully will increase that pressure within the glomeruli, and your glomeruli are now happy kidneys. Okay? Another thing that happens as part of the overall compensatory mechanism is ADH is released from the pituitary gland. And when ADH is released from the pituitary gland, you hold on to water. And when you hold on to water, it should increase again your intravascular volume, which should increase pressure in your glomeruli, and your kidneys are happy. All right, so that's basics of the renin-angiotensin-aldosterone system. So let's talk about a couple of medications. First medication I want to talk about has to do with ACE inhibitors. ACE inhibitors all end in pril, P-R-I-L. All right, they all end in prils. And an ACE inhibitor blocks the conversion of angiotensin 1 to angiotensin 2. So when you block the conversion of angiotensin 1 to angiotensin 2, then you don't have vasoconstriction and you don't have aldosterone release. The population of patients who really need ACE inhibitors are patients who have heart failure. I like to say it's like peanut butter and jelly, peas and carrots, salt and pepper. Every single patient who has chronic heart failure should be on an ACE inhibitor because you don't want their blood pressures to go up. It's much harder for those left ventricles to pump against a high pressure. And you certainly don't want them holding on to sodium and water, by no means. Okay, so they are ACE inhibitors. One of the things you have to worry about with ACE inhibitors, number one, are your labs. So when patients are put on ACE inhibitors, there is the potential that glomeruli pressure goes down. And if that should happen, your patient's potassium level may go up, as well as their creatinine level. So when you're giving somebody an ACE inhibitor, you want to pay attention to the potassium levels and their creatinine levels. And if they start to creep up, the physician may have to take them off that group of medications. Other things you have to worry about with ACE inhibitors, number one is one of the side effects, which is just annoying, but patients don't like it, and that is a chronic dry cough, most of the time happening at nighttime. So the patients can't sleep. So they want to go off their ACE inhibitors. Well, they can't do that because when they go off their ACE inhibitors, again, they're going to hold on to sodium and water. You go down that bunny trail where you don't want to be readmitted to the hospital because you're holding on to fluid again. So they can't stop it. So we're going to have to put them on another group of medications. The other thing that happens with some ACE inhibitors is that it can cause angioedema. And angioedema is a lot of swelling on the inside of the face and the neck and swelling on the outside. So these patients will come into the emergency department and their tongues are so swollen, they're hanging out of their mouths. Obviously, that's an airway issue. These patients cannot ever take an ACE inhibitor again. Okay? So those are the big things we worry about with an ACE inhibitor. So now your patient can't take an ACE inhibitor, but they really need to have this type of a medication on board. And the next group of medications we're going to work with then are called ARBs. ARBs block the process right here. So ARBs are angiotensin receptor blockers. They do almost the exact same as ACE inhibitors, but they don't have necessarily those side effects. And these medications all end in sartan. S-A-R-T-A-N. They're angiotensin receptor blockers. They end in sartans. Okay? Again, not so much the same side effects, and they just seem to be safer drugs. You still have to watch your potassium and your creatinine level, but otherwise they should be fairly safe. Okay, the only other drug I want to talk about here is aldactone. Aldactone, and this is the trade name, or spironolactone. Aldactone is an aldosterone inhibitor. So your chronic CHFers may be on aldactone along with Lasix, maybe or maybe not. The other way that students like to remember aldactone is it's a potassium-sparing diuretic. So if these patients are on Lasix, which is potassium wasting, and they're on aldactone, which is potassium sparing, then we don't have to worry about the K as much. We really do have to watch the values, but not as much. But another group of patients who are on aldactone are those patients who have cirrhosis. And when your patient has cirrhosis, they have a very hard time metabolizing aldosterone. So if you can't metabolize aldosterone, then you're going to do a lot of holding on to sodium and water. And in that patient with cirrhosis, that sodium and water, all that extra fluid, sits in that patient's belly, and it looks like that big belly with ascites. So when you give that group of patients aldactone, it helps them to now not hold on to that sodium and water because of that inability of the liver to metabolize aldosterone, and hopefully some of that fluid level in their bellies go down, and it's a lot easier for that patient to breathe. Okay, so that's aldactone. So I hope that this presentation has helped you a little bit with the renin-angiotensin-aldosterone system. Certainly if you have any questions about it, ask your lead instructor, and have a great day.